Cancer complications. Objectives for this lesson will be to describe side effect management of cancer treatment, explain myelosuppression and be able to calculate an absolute neutrophil count, and understand nursing implications, understand neutropenic diet and food safety, identify complications of advanced cancer, as well as evaluate pain management with advanced cancer. Myelosuppression is the most common side effect of chemotherapy and radiation that may result in serious life-threatening side effects. Side effects can include serious infections, bleeding and hemorrhaging, and significant overwhelming fatigue, with manifestations dependent on the type of therapy. Radiation tends to be more localized to areas being radiated, whereas chemo is more systemic that usually affects the bone marrow throughout the entire body. Myelosuppression's onset is dependent on the lifespan of the cell, and the severity is affected by the chemotherapy agents being used, the dosage, and the radiation field. Generally, radiation fields affecting large bone marrow containing regions tend to cause significant myelosuppression. These are usually areas of the pelvic, thoracic, and lumbar vertebrae. White blood cells are affected within 1 to 2 weeks. Platelets typically are affected within 2 to 3 weeks, and red blood cells are usually affected around 120 days. Neutrophils play an important role in the prevention of infections and are responsible for destroying pathogenic microbes. Neutropenia is defined as a total white blood cells less than 1,000. And neutrophils are closely monitored in the clinical practice setting as an infection risk, most often associated with absolute neutrophil count, or ANC. White blood cells are made up of granulocytes, monocytes, and lymphocytes, with a reduction in these resulting in neutropenia. ANC is calculated by multiplying the total white blood cells by the percentage of neutrophils. There are different levels of neutropenia, each level representing a different significant in infection risk. So neutropenia is classified as an ANC less than 1,000, where severe neutropenia is classified as an ANC less than 500. Neutropenia should also be assessed by determining if decreases were sudden or gradual, how severe the decrease has been, and how long the neutropenia has been taking place. The faster and longer the drop, the greater the likelihood of a life-threatening infection, sepsis, and or possible death. It's also important to consider patient comorbidities, the age of the patient, any existing infections, inpatient status, and diabetes. These may all increase the risk of infection. The most common cause of neutropenia is chemotherapy and immunosuppressive therapies. Other drugs can also cause this that may include anti-inflammatories, diuretics, antimicrobial agents, infection of bacterial, viral, and or parasitic, any nutritional deficiencies such as folic acid, transfusion reactions, hemodialysis, autoimmune disorders, hematology disorders, anemia, leukemia, myelodysplastic syndrome, any severe sepsis, or bone marrow infiltration. These patients are predisposed to infection with organisms from the normal body flora. Therefore, when the white count is low, normal destroying mechanisms are impaired and the body is unable to fight the infection on its own. This depressed immune response may also impair the normal infection symptoms such as inflammation, redness, warmth, swelling. Classic fever symptoms require immediate attention since these patients have little to no ability to fight infection. Little infections in a neutropenic patient can result in a full-blown sepsis in a matter of hours. Other symptoms to be aware of include a sore throat, dysphagia, ulcerative lesions, diarrhea, rectal tenderness, vaginal itching or discharge, any shortness of breath, or any non-productive coughing. It is crucial to determine cause of infection and treat promptly with correct antibiotic therapy. Neutropenic patients must be monitored by ongoing signs and symptoms of infection, such as fever and early septic shock. Obtaining timely blood cultures and starting broad-spectrum antibiotics with continued monitoring of infection is essential. Often these patients are put on granulocyte colony-stimulating growth factors such as Neupogen or Zarzio to prevent further neutropenia and reduce the severity and duration of their neutropenia. Hand washing is the single most important preventative measure that can be taken to minimize the risk of infection by staff and visitors before and after patient contact. Thrombocytopenia is a reduction of platelets below 150,000 with acute, severe, or prolonged decreases resulting in abnormal hemostasis manifested with prolonged bleeding. Often these patients are asymptomatic. However, the most common symptom usually is bleeding, such as mucosal or cutaneous. Typically, patients present with nosebleeds or gum bleeding or large bullous hemorrhages, usually on the tongue. Bleeding may be present as petechiae, purpura, or superficial ecchymosis. Petechiae are small, flat, pinpoint reddish or reddish-brown microhemorrhages that's usually seen on the abdomen, the arms, or the legs. Purpura are numerous petechiae clustered together that resembles a small reddish skin bruise, whereas ecchymosis is a larger purplish lesion usually caused by a hemorrhage. Patients will present with bleeding, prolonged bleeding following procedures, injections, hemorrhaging. Nursing care is based on diagnosing and removing the underlying cause, avoiding any anticoagulant or other blood thinning medications, monitoring platelet and coagulation studies, administration of platelet transfusions. Platelet transfusions are typically given when platelets are pretty low, usually 10 to 20,000, or if patients are pretty symptomatic with bleeding that's not stopping after about 10 minutes. But most of the time, patients do not need platelet transfusions unless it's consistently low. In this example on this page, you can see the difference between petechiae and purpura. You can see on the left side is the petechiae, and that is those little pinpoint reddish-brown dots on the arm. And then on the right side is the purpura, which are the petechiae that are more in cluster forms. They're in these red blotches, and they're on the legs. Absolute neutrophil count, or ANC, measures the percentage of neutrophils in the white blood cell count and is determined by multiplying the total white blood cells by the percentage of neutrophils, which again are segmented neutrophils and segmented bands. A normal value of an ANC is 1,500. Mild neutropenia is 1,000 to 1,500. Moderate neutropenia is 500 to 1,000, and severe neutropenia is anything less than 500. Nadir refers to the point in time where blood counts are at their lowest. This usually occurs 7 to 10 days following treatment. However, it's very important that nurses know where an oncology patient is in their treatment cycle in order to determine the appropriate care and if they're at a high risk for infection. That's one thing that a lot of doctors will want to know is if they are at their nadir. If they're at their nadir, usually that's why you'll see their counts as low as they are. Again, ANC is the estimate of the body's ability to fight infection, and it's very useful for nurses to know when assessing risk of infection. ANC is calculated by taking the total white blood cell count. So in this case, you will see the count is 1,600. And then the total number of polys, segs, and bands, which is the neutrophils. So you can see there's 48 polys and there's 5 bands. So when you add that up, it's 53. Then you convert the 53 to a decimal, which will be 0.53. And then you multiply the two together. So in this case, you'd take 1,600 times the 0.53, which equals 848. So based on the ANC of 848, this puts the patient at a moderate neutropenic risk. Cancer and cancer treatment weaken the immune system and predispose patients to infections when exposed to germs from the food. Neutropenic patients must be especially aware of their food choices and the way it's prepared in order to prevent unwanted infections. So back in the 1960s, infection-related deaths occurred in cancer patients. So to prevent further deaths, patients were isolated and the foods that they were ingested were highly sanitized and cooked to levels that were sure to kill microorganisms. These diets were known as neutropenic diets, and although it was not research-based, deaths seemed to decrease, therefore these diets remained to cancer patients. Flash forward to 2008 to 2018, where evidence-based and research-based practices were up and coming. Several randomized controlled studies showed no significant reduction in infection risk in those following these neutropenic diets. Therefore, these diets were phased out and instead replaced with effective food safety and preparation standards. According to the Academy of Nutrition and Dietetics, safe food preparation is key with neutropenic patients. Food safety begins with hand hygiene for at least 20 seconds before and after preparation. Fruits and vegetables should be washed thoroughly. Cutting boards should be reserved solely for preparing raw meat, poultry, and fish, and should be washed with hot soapy water and rinsed after use. Frozen food should never be thawed on the counter to room temperature, but rather thawed in the refrigerator or in the microwave. Food should be cooked using cooking thermometers in order to check temperatures and ensure that food has been cooked thoroughly. To reduce germ risks, foods should be refrigerated within 2 hours of cooking. If food is left outside higher than 90 degrees, it has to be thrown away after 1 hour. These patients should definitely be taught to look at the used by and best by dates when buying foods in the store, and they should be instructed to not buy if around these dates. Avoid buying foods from self-service bulk containers or bins because you cannot guarantee the cleanliness or the age of the food. Neutropenic patients should limit exposure to public, therefore should avoid crowded restaurants and places where food is not prepared directly in front of them. Buffets, smorgasbords, deli counters, potlucks, salad bars, sidewalk vendors, and the use of condiments that are shared by other people should all be avoided. Patients should avoid uncooked, undercooked meals that are made from high-risk food categories as well. So here is a critical thinking exercise where I'm expecting you to look at these labs and kind of think in your head what you would do if this was your patient. So a patient comes in for her day 8 nurse check following treatment last week. Results of her labs are as follows. So you can see by her white count is 2.5 with an ANC of 0.4. Her hemoglobin is 9.5, hematocrit of 37, and a platelet count of 55. What do you think of these labs? Are any of these normal? What labs are you concerned about? What nursing interventions would you use and why? Cancer treatment causes a lot of gastrointestinal side effects. The mucosal lining of the GI tract is highly proliferative, with cells being replaced about every 2 to 6 days. The GI tract is the most sensitive to radiation and chemo and is thought to be from the release of serotonin, which stimulates the chemoreceptor trigger zone and vomiting center in the brain, caused from cell death that results in damage to the GI mucosa and is affected on internal structures damaged from radiation. Common side effects from cancer treatment on the GI system include nausea and vomiting. This usually occurs within 1 hour of treatment and can last for about 24 to 48 hours after treatment. Often treatment is used when the use of antiemetics in the form of Reglan, Compazine, serotonin 5-HT3 receptor antagonists, substance P receptor antagonists, and steroids. Cancer treatments often cause irritation of the bowel mucosa that results in diarrhea. So diarrhea is best managed with diet modifications and anti-diarrheal, anti-motility, as well as antispasmodic medications. Patients are prescribed low-fiber, low-residue diets, and they are usually restricted of fatty, fried, gas-producing, and spicy foods. Patients should limit roughage foods such as fresh vegetables and fruits, seeds and nuts. Hydration and electrolyte replacement is essential to prevent fluid imbalances, and comfort measures with sitz baths, pain medications, assessment of skin integrity for areas of skin breakdown, and patient teaching with importance of keeping diarrhea logs are beneficial. Patients should keep note of the number, frequency, consistency, the volume, the characteristics of it, if there's any aggravating or alleviating factors. These can all help in determining interventions that will help control their diarrhea. Another common gastrointestinal side effect is mucositis. This is an irritation, inflammation, and ulceration of the mucosa that may affect the lining of the oral cavity, the oral pharynx, as well as the esophagus. Meticulous oral assessment and interventions to keep the mouth clean and moist are essential in preventing infection and improving nutrition. Patients should be taught the importance of assessing their mouth, performing oral care before and after each meal, and before going to bed, as that's when there tends to be the most bacteria in the mouth. Mucositis and thrush are often painful and very debilitating, affecting one's ability to eat and consume appropriate calories and protein to fight infections. Another common side effect is anorexia. This can be multifactorial with inflammation of the esophagus, mucositis, nausea and vomiting, taste alterations from treatment. It tends to peak at 4 weeks. Monitoring weight changes with signs and symptoms of dehydration are essential. These suffering patients should be encouraged to eat small, frequent meals that are high in protein and calories, often with the use of nutritional supplements such as Ensure or Boost. These patients should also be followed by an oncology dietitian who might be able to help assist them with their symptoms. Oral mucositis is a serious toxicity associated with chemotherapy and radiation and can be dose limiting. Treatment in the form of preventative and supportive care is important to improve their quality of life and prevent and reduce the severity of their symptoms. So this is a grading scale that is used for mucositis, and you can see obviously as the grades go up, the severity goes up. So grade 1, you can see there's soreness and plus or minus redness that is affecting the mouth. A grade 2, there's redness, there may or may not be ulcerations. They can swallow solid food, but it could be painful. A grade 3, there is ulcerations with extensive redness. They're unable to swallow solid foods. Redness can be present on most of the mucosa. It's painful ulcerations. And then you can see a grade 4 is the most significant. Ulcerations are present with extensive redness. There's a no swallowing ability. The redness is present on most of the mucosa, and extensive painful ulcerations are present. So in practice, mucositis is very common and it occurs in varying degrees depending on the length of treatment, the drugs that are being used. Often chemotherapy is administered using multiple drug therapies, therefore increases the risk of mucositis. So years back, I had a metastatic breast cancer patient being treated with Abraxane, which is a taxane-based single-agent treatment for advanced cancer. She had her first dose of treatment and came in a week later for a nurse check, and she had significant issues with mucositis. Her mouth was covered in ulcerations. Looked like she had a stage 3 to 4. There was ulcerations on her gum line, her tongue, her lips, the back of her throat. She had thrush on her tongue. She was unable to eat or drink. She took in very little and had significant pain with swallowing. She was subsequently prescribed some antifungal medications of diflucan. She was given magic mouthwash and instructed to do some saltwater baking soda rinses several times a day. She did come in the following week. Symptoms had significantly improved, and she was able to resume her treatment. However, her doses were decreased to help prevent further toxicity with mucositis. Here's another critical thinking exercise. So a patient comes in on day 15 following treatment of R-CHOP for her follicular lymphoma. Your assessment is as follows: severe fatigue, weakness, she's lightheaded with position changes, dry mucous membranes. She's had a 6-pound weight loss over the last week, having a decreased appetite with little to no intake due to severe pain with swallowing. Upon inspection, you notice a grade 3 mucositis with a white coating to the tongue, ulcerations on the tongue, the gum line, and on the bottom lip. What do you think of this assessment? What other data would you want to know? What about vital signs? What about signs and symptoms of dehydration? You'd probably want to know when the appetite decrease started, if there was any aggravating or alleviating symptoms to the pain. When looking in the mouth, what are you expecting to find? You want to know what they're eating. A 6-pound weight loss in a week is pretty concerning. As you remember, maintaining appropriate weight with protein and calorie intake is important with these patients. So therefore, it's pretty important that we keep an eye on her weight. We also want to ask if there's any supplementation that she's been taking, any Ensure, any Boost. Ask if she's been following a dietitian. You might want to look in the mouth to get a thorough assessment of the mucositis. What do you see? What are you concerned about? What about her nutritional status? What about her labs? Are you looking at any electrolytes? What about longevity on treatment with this continued mucositis? Will they be able to give her treatment? What do you think would be in the anticipated orders or nursing intervention for this patient? Do you think the doctor will prescribe any IV fluids? What about that thrush? Do you think they'll prescribe any antifungal medications? Any diflucan? What about dietary changes? What kind of diet would you recommend for them to take? Many different skin reactions occur with cancer treatment depending on the treatment being used. Often radiation therapy will cause redness to the site being radiated, usually within 1 to 24 days. Skin reactions are more prominent in areas of skin folds where pressure is being exerted. So the goal of treatment is to prevent any infections and promote wound healing. So nursing interventions with patients that have severe skin reactions essentially is to protect the skin from extremes in temperatures by avoiding any heating pads, any ice packs, any hot water bottles. You want to recommend wearing loose-fitting clothing to avoid any kind of constriction. Use fragrance-free, skin-sensitive lotions or deodorants. Avoid dry skin by keeping the skin moisturized. Prevent any infections by keeping the skin clean. Another major skin reaction that is very common is alopecia. This is a reversible side effect that varies from localized to systemic therapy based on the therapy being used. Hair tends to come out in clumps, usually begins 3 to 4 weeks after the start of treatment, often coming back with different colors and or textures. Often these patients will participate in a Look Good, Feel Better program. It's an added support resources that's available for patients that are, it kind of offers tips on skincare, hair care, makeup for cancer patients going through treatment. It's a face-to-face meeting, usually with a trained cosmetologist that meets with the patients to go over appropriate and beneficial skincare that can be used throughout treatment. I've had many patients that have participated in this program and they loved it. They actually go home with a $100 cosmetic bag, and they learn a lot of great things on self-care that helps get them through this treatment. Here is a picture of wet desquamation. So remember, desquamation is basically skin peeling. It's the shedding of the outermost membrane or layer of tissue, in this case the skin. Moist or wet desquamation is the clinical pattern seen because of radiation exposure, where the skin tends to thin and then begins to weep because of the loss of integrity of the epithelial barrier and decreased oncotic pressure. Clinical symptoms include sloughing of the epidermis and exposure of the dermis, blister or vesicle formation, and serous drainage with pain. Assessment to include, you want to always look at the location of the moist as well as the dry areas, the size of the area. You want to look at the wound base to determine what kind of tissue you're looking at. Is it granular, eschar, or necrotic? You always want to look at the discharge. What type, amount, and odor? Discomfort level, you want to look at what their pain level is. Is it burning, itching, pulling, tender? Signs and symptoms of infection, looking for fever, any foul odor, any purulent drainage, pain and swelling that extends outside of the treatment area. Treatment for these patients, when moist desquamation occurs, the area should always be kept clean to prevent any kind of secondary infections that may require an application of a burn type dressing. Patients are instructed to use sunscreen over the irradiated areas after the completion of treatment. They can use a moisture retentive protective barrier ointment after a saline soak. Sometimes they consider the use of hydrogels as well as non-adherent dressings. You definitely don't want to put a dry dressing on an open area like that. It would be very painful when it came off. You want to use absorbent dressings over the non-adherent dressing, obviously to soak up the drainage. You want to change the dressings as the drainage warrants and control the drainage. You want to consider using hydrocolloidal dressings to help with that. Radiation is often a treatment that is done in combination with chemotherapy and at times may cause significant skin toxicities. Skin changes are experienced for up to 95% of patients undergoing radiation, and significant skin reactions often have a great impact on the progress of the radiation. A few years back, I had a lung cancer patient who was receiving weekly chemo and radiation to his chest and had significant skin toxicities with this wet desquamation appearance. It subsequently resulted in delays in his treatment, and they had to hold radiation a few times. He suffered with extensive discomfort and pain. He had open weeping wounds to the right side of his neck and ultimately required wound care with ointments and hydrogel dressings. His weight began to decline. His nutritional status declined. He wasn't able to eat or drink. He wasn't taking enough protein or calories. And he eventually, due to the severity and the toxic skin effects that can occur with radiation, prevention is the most ideal thing with these patients. So patients should be instructed to wash their skin with mild soap and lukewarm water to maintain a skin barrier and decrease the risk of radiation-induced skin reactions. Patients should be instructed to wear loose-fitting clothing, avoid sun exposure, avoid metallic topical products, and use water-based lipid-free moisturizers to prevent any post-radiation complications. Traditional treatment of radiation-induced skin reactions usually include topical steroids, creams and ointments, as well as hydrogel dressings. This is an example of hand-foot syndrome. It's also called palmar plantar erythrodysesthesia. It's a side effect pretty common to some cancer treatments. Hand-foot syndrome causes a redness, swelling, and pain to the palms of the hands and the soles of the feet. Sometimes blisters can appear. Hand-foot syndrome sometimes happens usually in the skin folds or in areas of friction such as the knees or the elbows. That is less common, but it does happen. Symptoms usually are redness that appears like a sunburn, swelling, a feeling of tingliness or burning, tenderness or sensitivity to touch, and a tightening of the skin, Thick calluses and blisters on the palms of the hands and the feet might happen. Severe cases will notice cracked, flaky, or peeling skin, blisters, ulcers, or sores on the skin with severe pain and difficulty walking or using their hands. Prevention. Hand-foot syndrome is usually worse during the first 6 weeks of treatment. Chemotherapy, it usually occurs after about 2 to 3 months. It limits the use of hot water on your hands and feet when washing dishes or bathing. Patients want to take cool showers or baths, carefully patting their skin after washing instead of rubbing. They want to cool their hands and feet using ice packs, cool running water, or a wet towel for about 15 to 20 minutes at a time. You want to try avoid applying ice directly on the skin. Avoid sources of heat, including saunas, sitting in the sun, or even sitting in front of a sunny window, because that can actually make their hand-foot syndrome worse. They obviously want to avoid activities that may cause force or friction, rubbing on the hands or the feet during the first 6 weeks of treatment. This might include jogging, running, any kind of contact sports. They avoid contact with harsh chemicals used with laundry detergents and household cleaning products. They want to try to avoid using rubber or vinyl gloves without a liner to clean with hot water. Rubber traps heat and sweat against the skin, so they want to try using maybe some cotton gloves underneath the rubber gloves. Avoid using tools or household items that require pressing against a hard surface. This may include gardening tools, knives, screwdrivers, that kind of thing. They want to gently apply skincare creams to keep their hands moist. Avoid rubbing or massaging the lotion directly into the hands and feet. This type of movement obviously can create friction and make their symptoms worse. We're going to recommend wearing loose-fitting clothing, well-ventilated shoes, and clothes so that the air can actually move a little more freely against their skin. Try not to walk barefoot. They want to use soft slippers and thick socks to help prevent friction on the feet. Consider visiting a podiatrist to remove any thick calluses and nails before they begin treatment. Obviously, they don't want to do this during treatment because that can obviously lead to infections and whatnot. So podiatrists are usually pretty beneficial. They can usually recommend products that can lower the friction and put less pressure on their feet. Treatment of hand-foot syndrome revolves around topical pain relievers such as lidocaine. There's different kinds of lidocaine patches that they can use, topical moisturizing exfoliant creams, either by prescription or over the counter. Pain relievers such as ibuprofen, naproxen, or Celebrex. Definitely want to tell their doctor if they're already taking any of these, or if they're taking any other non-steroidal anti-inflammatories. Ice packs under the hands and feet while chemotherapy is being given sometimes is used to help prevent some of those symptoms. However, there's not any research that's showing any promising results from using ice during treatment, so I actually don't really see that much in practice anymore. Hand-foot syndrome is a very unfortunate but sometimes unavoidable skin toxicity experience with the use of certain chemotherapy treatments. I can remember years ago taking care of a young female metastatic ovarian patient who had been treated with basically just about every FDA-approved regimen, and this was kind of a last-ditch drug. She was put on Doxil, which is an anthracycline antibiotic used with ovarian cancer. And although the Doxil was working, it was reducing her tumor marker and it was showing regression of her tumors. It also resulted with this significant hand-foot syndrome. I remember one day her coming into the clinic with significant swelling, skin tightening, redness, sensitivity, and pain, peeling and cracked skin. She couldn't even really move her hands. It just looked like someone just poured acid on her palms. It was horrible. Due to the severity of the skin reaction, her treatment had to be stopped and discontinued, as these toxicities were just way too severe to continue her treatment. Chemotherapy and radiation therapy also has pulmonary side effects that can be pretty progressive and sometimes irreversible on patients. It can be acute and chronic. They can be immediate or delayed. Pneumonitis is a delayed acute inflammatory reaction that usually occurs 1 to 3 months following the completion of thoracic radiation and often has little to no symptoms. Symptoms may include coughing, fever, night sweats. Other issues they might have would be pulmonary fibrosis. This is a late effect that may follow pneumonitis when lung tissue becomes damaged and scarred. This thickening, stiff tissue makes it very difficult for the patient to breathe and work properly. As pulmonary fibrosis worsens, they become progressively more short of breath and have increased anxiety with that. Common toxicities of chemotherapy include pulmonary edema that's related to capillary leak syndrome or fluid retention, hypersensitivity pneumonitis, interstitial fibrosis, and pneumonitis. Treatment of respiratory compromise is usually just supportive care that may include bronchodilators, steroids, expectorants with cough suppressants, oxygen, and rest. A common pulmonary toxicity that is seen quite frequently in oncology is pneumonitis, which results with non-infectious lung inflammation. I can remember about 2 years ago having a lung cancer patient who was being treated with an immunotherapy of Opdivo, was started having increased shortness of breath, persistent dry cough, low-grade fevers, general fatigue. What's challenging about lung cancer patients is they already come in with diagnosed increased shortness of breath and coughing. Therefore, determining if their symptoms are worse can sometimes be a little confusing. This particular patient had a unique case in the fact that since he was spiking fevers, he was subsequently admitted with pneumonitis and underwent a bronchoscopy, which resulted in finding a cap to one of his insulin syringes in one of his bronchioles. In all my years of practice, that was the first. I was shocked, surprised that this had even happened. Who only knows when this took place? The cap was removed. Patient was then treated for a pneumonitis with a course of steroids. Treatment is typically symptomatic and usually involves a course of steroids and or holding or discontinuing immunotherapy indefinitely. This patient did recover. He came back to the clinic, and of course that was the story of the day. And he just remembers years or months before going to the hospital, being admitted, and he was in the middle of doing his inhaler, and he remembers grabbing his inhaler on top of a Kleenex, grabbed the Kleenex, and somehow the cap was in there. And when he went to inhale, he remembers feeling something funny go in his throat. He coughed a little bit, and then that was the end of it. So he didn't even have any idea that the cap was even in there. So who only knows how long that cap was in his bronchiole. But no wonder he had some coughing fits after that. Cancer treatments with chemo and radiation may have significant cardiac effects to the pericardium, the myocardium, the valves, the blood vessels of the heart. That puts patients with underlying cardiac comorbidities at an increased risk. Many chemotherapy drugs, such as anthracyclines, cause cardiac toxicities and subsequently are capped after certain doses that protect the heart. Acute toxicities include abnormalities in ECG findings. Late toxicities could be left ventricular dysfunction and or heart failure. Often treatment protocols require baseline and periodic MUGA or echo scans that are based on results. Will recommend dose reductions and or cardiac oncology consults. In some cases, treatments may need to be held, stopped, or discontinued permanently based on the results of these testing, and which can lead to poor prognosis and potential deaths. Although chemotherapy is used to kill off cancer cells, often it kills off important necessary cells such as the cells of the heart. Patients that are receiving chemo that is known to cause cardiac toxicities will require baseline and periodic echocardiograms throughout treatment to monitor heart function. Cardiac toxicity is usually defined as a reduction of the ejection fraction less than or equal to 5% to less than 55% with symptoms, or heart failure, or an asymptomatic reduction of the ejection fraction less than or equal to 10% or less than 55% in So in practice, when I'm taking care of these patients receiving drugs that I know may cause effects on the heart, I'm routinely monitoring their echocardiograms. Often our chemotherapy protocols are built with this right in their system, usually every 3 months, but again, it's based on their previous results as to when the physician would want to do another one, but usually it's every 3 months. Recently, I actually had a long-standing patient who I've been taking care of since 2017 for advanced prostate cancer, and over the last few years, he actually has had a significant decrease in his ejection fraction. Due to his increased risk for his treatments, he has had routine echoes to manage his heart function and he had been stable up until about January. So back in 2017, he had a baseline echo that showed an ejection fraction of 45%, which for him was stable. However, over a 3-year time span, it actually decreased down to 35% in January. So his treatment was stopped. He had to follow up with a cardiac oncologist that evaluated him a little bit further. And then in the end, he ended up putting him on a statin, a beta blocker, and a diuretic, and agreed to kind of continue his treatment, but with careful monitoring. He continues to be at his baseline, however, continues to be managed frequently for his progressive symptoms. He's pretty tired all the time, can't really go up a lot of flight of stairs. He's very restricted in his ability to ambulate. So they're just watching him very carefully, and he is following up with his cardiac oncologist quite frequently. So you can see by this example that not only do oncology nurses need to know their drugs, but they must also be aware of potential cardiac complications and be competent to know when to question potential complications. With advancing cancer treatments, patients are living longer and developing long-term late effects from treatment. So late effects are often progressive and permanent, and they can vary based on the treatment that's used. Late effects of radiation could include strictures, fistulas, radiation necrosis, whereas late effects of chemo could be cardiac toxicity, like we discussed in the last slide, cataracts, arthralgias, endocrine alterations, renal insufficiencies, hepatitis, osteoporosis, neurocognitive dysfunctions. A lot of times they can have fertility issues and even secondary malignancies. Late effects tend to worsen based on the treatment used, with multi-treatment modalities increasing these risks. Secondary malignancies are pretty common years after the initial cancer treatment and are often related to treatments used with their first cancer, especially those treated with alkylating and high-dose radiation treatments. Remember, alkylating agents cause breakage of the DNA strands, affecting the ability of the cancer cells to multiply. And secondary malignancies may include leukemia, angiosarcomas, skin cancers. They are something as an oncology nurse I unfortunately see quite frequently. Often patients will get diagnosed with cancer, go through some rigorous treatment with the subsequent remission. However, years later, they present with another type of cancer, most often a blood cancer in the form of leukemia. I recently started treatment on a past patient of mine who about 6 years ago was treated for multiple myeloma, which, if you know, it's a cancer of the plasma cells. And he was given an alkylating agent. After 12 cycles of treatment, he was placed on a maintenance therapy to keep him in remission. He was doing very well for many years. However, recently was seen and diagnosed with the myelodysplastic syndrome, transitioning into leukemia, most likely related to his treatment with his Velcade, which is that alkylating agent he had. Other times I've had patients will come in, I'll see a breast cancer patient who presents years later following extensive radiation and chemotherapy with some sort of leukemia. So unfortunately, the treatments that are proven to cure the patient from one cancer may predispose them to get another type of cancer years later. Cancer pain is a common debilitating side effect with cancer, and often this goes untreated. It's actually reported that moderate to severe pain affects nearly half of all cancer patients, with nearly 80 to 90% of those with advanced cancer. Under-treatment of cancer patients results in needless suffering, decreased quality of life, and increased caregiver burden. Effective pain assessment is essential. The single greatest barrier to effective pain management is effective pain assessment. Nurses must be knowledgeable and educated on appropriate pain assessment strategies and be able to decipher persistent and episodic, positional, or breakthrough, various types of presentations of pain, and be able to manage pain effectively. Pain assessment is an ongoing process, and nurses must validate pain when it is reported. Remember, pain is whatever the patient says it is. And so nurses should never judge a patient based on just objective data. So just because the patient might not look like they're in pain does not mean that they're not in pain. A helpful mnemonic with pain is using the PQRST mnemonic. So P is provoking symptoms, Q is quality, R is radiating, S is severity, and T is timing. So that's a good mnemonic to remember whenever you're asking questions about pain. Pain management therapy is multifactorial and should include pharmacological as well as non-pharmacological interventions that is patient-centered and individualized based on pain symptoms. So pain must be controlled for both persistent as well as breakthrough pain and typically involves immediate release as well as extended release narcotics. Pharmacological interventions may include nonsteroidal anti-inflammatories, opioids, adjuvant pain medications, and it's always important to remember that medications should be chosen based on the character and the cause of the pain, with opioids typically being prescribed for moderate to severe pain, administered usually pretty scheduled, with supplemental medications available for breakthrough pain. Side effect management is a very important topic to consider when teaching patients about the use of narcotics, as often side effects can be quite bothersome for these patients, especially in the form of constipation. Patient teaching should focus on the fear of addiction, but it's not warranted. So, however, it should be included in their teaching, as often patients are usually pretty concerned about this fear. Goals of therapy should be addressed with patients needing long-term chronic pain management. You want to clarify myths and misconception of pain management. Often patients fear they're going to die in pain. Rather, pain can be very effectively managed and to maintain the quality of life and comfort, and they should know that. Non-pharmacological interventions of pain management include relaxation therapy, guided imagery, massage therapy, Reiki, acupuncture, aromatherapy. I know at my office we use a lot of integrative medicine such as this that we actually have positioned right in our infusion room where patients can participate if they choose to right in their chemo chair. So patients that do participate in these forms of therapies tend to think that they do work very well for them. Nurses are influential in helping patients cope with many psychological issues that are associated with cancer during a time of uncertainty. Patients often have many concerns about the unknown. They become fearful of what the future may hold. They often have fears of being dependent on someone, losing control, stress on close relationships, financial burdens with continuing treatment, anxiety and fear of death and leaving people behind. Nurses are key members of the healthcare team to assess these needs, and they can tap into great resources that may assist patients and their families. Nurse attributes to help with cancer patients include availability, caring, listening, providing great resources, building therapeutic relationships of trust and honesty, helping with goal setting, providing spiritual, physical compassion, maintaining hope and reassurance, and also collaborating between healthcare teams. Religious and spiritual values are very important to patients coping with cancer. However, may have different meanings and serious illness, such as cancer, may cause spiritual distress. Many patients with cancer rely on spiritual or religious beliefs and practices to help them cope with their disease, known as spiritual coping. Each person may have different spiritual needs depending on their culture, their religious background, and for some terminally ill, spiritual well-being may affect how much anxiety that they feel about death. So often providers will perform spiritual assessments to understand how values and beliefs may affect patient responses. Patients with cancer who rely on spirituality to cope with the disease should be able to count on the healthcare team to give them support. Nurses may assist patients with their spiritual needs by hopefully suggesting goals and options to care that honor the patient's spiritual and/or religious views, support the patient's use of spiritual coping during their illness. It can encourage the patient to speak with his or her religious or spiritual leader. They also can refer patients to a hospital chaplain or support group that may help with their spiritual issues during their illness. And they also can refer the patient to other therapies that may have been shown to increase their spiritual well-being, that may include mindfulness relaxation, such as yoga or meditation, creative art therapy, such as writing, drawing, or music therapy. What are your thoughts on that? What are your feelings? Do you have any concerns? Does working oncology interest anyone? On a personal note, I always wanted to be a nurse from the time I could remember. When I was 6 years old, my sister was born at 27 weeks. For the majority of her first year of life, our life revolved around a hospital. It was the constant dedication, caring, inspiration, and comfort that the nurses offered that made me realize that one day I wanted to be that inspiration to someone who that needed that at the most. Although a NICU opportunity never presented itself to me, an oncology position did, early in my career, and to this day I am so grateful and appreciative to those who mentored and guided me in my practice to make me the nurse I am today. Being an oncology nurse has been the most rewarding and humbling experience in my life, and it is not a job, but rather a calling that I was destined to do. Each day my patients have taught me important lifelong lessons, and because of them I view life and the world in a different light. Things that were once so trivial do not seem so trivial anymore, and I have learned to appreciate and cherish the life I have been given in God's work that I was called to do. Whatever and whenever your life and career take you, please remember to cherish each moment you are placed on this earth, and always remember to live life to the fullest and trust in the Lord with all your heart. Any questions or concerns?